of Gujarat, India, Gangaba Yagnik Nari Puraskar, also Professor K.C. Basu Malik Research Award by IAPM, and Madam has received honorary D.Litt degree from SNDT Women's University, Mumbai, Maharashtra. She has been received many outstanding research awards in international conferences like TTS, CTS. She is editorial board member for many national and international committees. And Madam has been former Vice Chancellor for Gujarat University of Transplantation Sciences. Also, Professor and Head for Department of Pathology, Laboratory Medicine, Transfusion Services, and Immunohematology, and Professor for Department of Stem Cell Therapy and Regenerative Medicine at IKDRC Ahmedabad. She is the first recognized teacher for PDCC, Renal and Transplant Pathology of India by Indian Academy of Pathologists. She has two patents. She has two patents for her credit: a method of preparing mesenchymal stem cells from adipose tissue and human adipose tissue derived insulin, making mesenchymal stem cells for treating diabetes mellitus. Over 235 publications, 14 book chapters to her credit, and more than 100 oral presentations. And also, Madam has been the former vice president for basic sciences of Indian Society of Organ Transplantation. She has been contributing in research activities with the original contributions mentioned in tolerance in alloimmunity and autoimmunity, history and evaluation of renal diseases in the Indian population, stem cell biology and research. And we, while reporting, quote her all these articles. And we are very fortunate to have here today respected Dr. Aruna Vanikar, Madam. We are eager to hear you. Over to you, Madam. Thank you.
Yeah. So greetings to all of you. Today we are going to discuss about one of the most important aspects of immunology in renal transplantation, which is the antibody-mediated rejection, and what are our perspectives, or say my perspectives, and what is it that all of us should remember. Now, this is not going आगे नहीं जा. Just 1 minute, Himanshu, I'll have to take a break. ये आगे नहीं जा रहा है, क्या करना है? I'm sorry.
Start, ma'am.
Yeah. So greetings to all of you. Today we are going to discuss an important topic in the renal transplantation, which is the antibody-mediated rejection, our perspectives. I would say that this is one of the most important immunological events that one has to remember. Before starting, I would like to put this disclaimer that presentation made here is from my previous experience and personal publications. During my tenure at the Department of Pathology, Lab Medicine, Transfusion Services and Hematology, and the Department of Stem Cell Therapy and Regenerative Medicine. The references taken here are from the available literature, which are free for use through the IT mode, and there is no conflict of interest of any kind in this presentation. So before we start with the index case, let me just give a brief idea about the antibody-mediated rejection. All of us know, especially we in our land, that Ganesha was the best model of organ and xenotransplantation in the world of transplantation, and this was never rejected. The two major points for which we should be happy to learn, or we should be proud of, is it was xenotransplantation and organ transplantation, and all of it has always been successful. So that means there is a lot of immunological work involved here. To start with, we will begin with this index case. A 31-year-old man underwent renal transplantation for CKD of unknown etiology with a haplomatched donor who was 46 years old lady. This transplantation happened on 21st of October 2015 and was under the standard immunosuppression protocol of TAC 0.05 milligram per kg body weight per day, mycophenolate 360 milligram QID, and PRED of 10 milligram per day. 15 days post-transplant, he had to undergo biopsy because of the rise in serum creatinine of 1.9 from the baseline of 1.5 milligram per DL. Rest of the parameters on clinical examination, graft, and the labs were all within normal indices. So this is the biopsy. As you can see, it is adequate. We can see here totally 5 glomeruli in the 2 bits here put here. And there is significant acute tubular injury, as we can appreciate, and there's an artery here. Further going down, here we can appreciate that there is glomerulitis. There is some tubulitis as well, and the PTCs are showing infiltrating mononuclear cells. So four things are appreciated here. Acute tubular injury. There is some tubulitis also. There is glomerulitis, quite significant, and peritubular capillaritis. C4D was negative here, but you can appreciate, and there was no arterial inflammation also. So there was no intimal arteritis, but there is infiltration in the interstitium with the mononuclear cells. The PTCs are involved. As you can see, there is peritubular capillaritis. So this was diagnosed as acute antibody mediated, and I was very fond of calling it as B cell mediated rejection, because antibody mediated is usually induced by the B cells and cellular mediated rejection is the T cell. So I have always been calling it as the B cell mediated rejection and the T cell mediated rejection. So it was combined AMR with T cell rejection. BAMF update to 2013. It was type 2 plus 4. The score was AG2, AT1, AV0, AI2, and PTC score was 2. However, C4D was negative by IHC. So what did we do? We had to address to both T cell onslaught and the B cell onslaught. So the T cell attack was controlled by R-ATG, rabbit ATG, 1.5 milligram per kg body weight with MP 500 milligram for 3 days. Plasmapheresis 3 sessions were followed by IVIG after each session. And of course, plasmapheresis was on 3 alternate days. And when we looked in the follow-up more than a year later, on the 23rd January 2017, there were no DSAs. Serum creatinine was 1.08, and he was on immunosuppression of TAC 0.05, MMF or mycophenolate sodium 360 milligram QID, and PRED of 10. So one thing we have learned is that whenever there is an immune injury, antibodies are one of the most important events to cause the injury. In the early days of the transplantation, there was always a kind of disagreement between Peter Gorer and Peter Medawer. Gorer said it is antibodies which are causing injuries, whereas Peter Medawer said it is the cell-mediated injury which is causing rejection. Of course, Medawer was awarded the Nobel in 1960 for his seminal work along with Burnett, and of course, Peter Gorer passed away in the times, and then nothing was talked about the antibodies for many years. Later on, other people took it up, and one of the seminal works has been done by Terasaki and group. This is again a borrowed slide from Terasaki, which shows that once there are antibodies, the HLA antibodies, they definitely affect the graft. And as you can see here, there is a reduction in 50% of the graft survival as the time goes by. As you can see here, from 12 months to 60 months, the survival has gone down to 50%. The experimental proof again he has shown that if there are no antibodies, the half-life is 13 years. But if there are antibodies, of course, the half-life goes straight to 5 years. And again, if it is HLA antibodies, it is more severe injury than the mica, which is a or the non-HLA antibodies. Of course, any kind of antibody, it affects the graft, but HLA class 1 and 2 antibodies, they will damage the graft definitely. And over the time period, as you can see, it affects the graft and causes detrimental changes. What are the stages of antibody-mediated rejection? So when we see in the clinic, it is too late. It all starts at the tissue level. The first stage, which happens in the first 6 months, is the appearance of alloantibodies. If there weren't any, the de novo alloantibodies will begin to appear. So if you measure them in the serum, you can see them, but you will not be able to detect them in the first 6 months by any other methodology. Second stage is when the C4D can be detected in the tissues along the peritubular capillary membranes, followed by the histopathology, where the transplant glomerulopathy will occur when the injury has already proceeded further to cause chronic changes. And when on the bedside, it's after a year that there is a severe injury, chronic rejection is there, and this could lead to graft loss. So coming to the histopathology or the diagnosis of ABMR, the revised BAMF 2013 classification of ABMR said that acute or active ABMR, all 3 lesions must be present for diagnosis. 1, histological evidence of acute tissue injury, including 1 or more of the following. 1 is the MVA or the microvascular inflammation, which includes glomerulitis more than 0 and or peritubular capillaritis more than 0. Of course, we here exclude recurrent glomerulonephritis. There should be intimal or transmural arteritis with V more than 0. There could be acute TMA, that is in the absence of other causes, and ATI or acute tubular injury in the absence of other apparent causes. Second is evidence of current or recent antibody interaction with the vascular endothelium, which includes at least 1 of the following. Linear circumferential granular C4D staining pattern along the peritubular capillary membranes. So it should be C4D2 or C4D3 by immunofluorescence on the frozen sections, or more than C4D0 by IHC on the paraffin sections. And of course, these will be the polyclonal antibodies on the IHC. And at least moderate microvascular inflammation, which means G plus PTC should be 2 or more. If there are facilities available, one can even account for looking to increased expression of the NDATs, that is the gene transcripts in the biopsy tissue, which are indicative of endothelial injury if they are thoroughly validated. Third, serological evidence of the donor-specific antibodies, which could be the HLA class 1 or 2, or MYC or other endothelial antigens. As against acute injury, what do we see in the chronic active antibody-mediated rejection? All 3 features should be present for diagnosis. First is morphological evidence of chronic tissue injury, which includes 1 or more of the following. First, transplant glomerulopathy, where CG is more than 0 that means there is reduplication of the glomerular basement membranes. If there is no evidence of chronic thrombotic microangiopathy, severe peritubular capillary basement membrane multi-layer layering, which requires EM, and even if one single PTC shows 7 layers, then it is enough to establish it as chronic active ABMR. And then, of course, the arterial neointimal fibrosis without elastosis. This should exclude other causes. Second is evidence of current or recent antibody interaction with vascular endothelium, which includes at least one of the following. Linear circumferential, again, same granular C4D staining in the PTCs, that is C4D2 or 3 by IF or C4D more than 0 by IHC. At least moderate microvascular inflammation, that means G plus PTC 2 or more, and increased expression of gene transcripts as we talked earlier. Third, of course, serological evidence of the DSAs, HLA or other antigens as we noted in the acute ABMR. Now, how do we interpret the C4D? The guidelines are, the very good thing is that you don't require cortex. Suppose cortex is not there, even medulla is enough to decide for the C4D interpretation. Minimal sample for evaluation is 5 high power fields of cortex and or medulla without infarction or scarred area, because these give false negativities. Hence, we don't look to the infarction or scarred area. It has to be viable tissue, either cortex and or medulla, and 5 high power fields. And we look for linear, circumferential, finely granular deposits of C4D along the peritubular capillary basement membranes. C4D can be 2 or 3 by IF and more than C4D 0 by IHC. So these are the guidelines for C4D interpretation. Now, what are the definitions of C4D staining patterns? So the percentage of biopsy area, it could be cortex and medulla, and how do we interpret according to the technique? So C4D 0 means it is negative all across. There will be no deposits on the of the C4D on the peritubular capillaries. C4D 1 is minimal, that means up to 10%. And this would be negative on the IF. C4D2 is focal when it is up to 50%. C4D3 is diffuse, that means more than 50% of the PTCs are positive. Now, what is the relationship between the C4D with antibody mediated rejection? C4D positive ABMR, it represents more severe form of the acute antibody mediated rejection, but microvascular injury, that is glomerulitis and peritubular capillaritis, are more strongly associated with graft loss than C4D deposition. That we should always remember, that with severe glomerulitis and PTCs, you are likely to lose the graft if it is than the C4D alone. Now, C4D positive and C4D negative ABMR both show similar degrees of glomerulitis and peritubular capillaritis. Both show equal frequencies of concurrent cell-mediated rejection, and both may occur early or late post-transplant. So all of them can occur at any time post-transplant in the life of a renal allograft. C4D negative microvascular injury has the potential to progress to IFTA, that is interstitial fibrosis and tubular atrophy, transplant glomerulopathy, and eventual graft loss if it is not treated promptly. That means that if there is C4D positive, then of course you have to be aggressively treating, but C4D negative also, please take it seriously. If there is all the evidence of antibody of immune injury, it should be treated. Now, what about the focally positive C4D? It's clear that if it is more than 50% of PTCs are involved, either in the cortex or medulla, we call it as diffuse C4D positive. But if it is less than the 50%, then it is called as focally positive C4D. So what happens? Now, diffuse C4D, it was found out by Podwal et al. That it had high rate of graft loss 1 year later than those with focal or no C4D deposits. 65% versus 33%. But the overall outcome with diffuse or focal C4D was not distinguishable, and it was worse than those without C4D. That means what this group, the group of Magill and et al. Say, that if C4D is positive, focal or diffuse, it is definitely going to be worse compared to C4D. And diffuse is more serious than focal, is what the other group says. Now, C4D staining of more than 25% of the PTCs by immunohistochemistry, it was associated with decreased 1-year graft survival, as was noted by Lawrence et al. So one thing is clear, that C4D positivity, that means we must be alarmed by it and be aggressive in the management. Now, if there is C4D staining without evidence of rejection, what do we do? This is noted with ABO incompatible transplants, where, and also it can be seen in the lupus cases. Now, if there is linear C4D staining in the PTCs, either 2 or 3 by IF and more than C4D 0 by IHC. Along with the C4D deposition, there should be G0, PTC0, CG0, V0. That means there is no glomerulitis, there is no peritubular capillaritis, there is no microvascular injury or arterial injury, and there is no tubular injury as well. Plus, there should be no thrombotic microangiopathy or PTC multilayering. It is only C4D staining, that's all. And no other immune injury, either cellular or humoral. Then it is termed as accommodation, and this has been noted in ABO incompatible transplants. And in fact, if you want to have a slide for a control, you can, for the C4D stains, you can take up a graft biopsy of either a case of ABO incompatibility or a lupus. How does C4D get deposited? The complement pathway, as all of us know, we studied in immunology, it is either classical pathway, alternative pathway, which starts at C3, or the lectic pathway. The most important is the complement pathway, the alternative pathway, and classical pathway. What happens is that with the exposure of the body to the allograft, which is an allo antigen in the initial period, and later on it could be an autoantigen or also. So basically, antigen exposure will evoke IgG or IgM HLA antibody response, and this will cause this C1 activation, C1q cleaving to C1rs. This C1q will then act on the C4 and cleave it to C4a and b. C4b will then lead to C4d formation, which will go into the tissues on the peritubular capillaries and get covalently bound to the tissue membranes. This C4b will then act on the C3, causing cleavage of the C3 to C3b and C3d. This C3d is also covalently bound to the tissues along with C4d. And C3b will then act on the C5, complement 5, which will then evoke the whole cascade from C5b to 9, which is a membrane attack complex. So this is one way of the classical pathway and the alternate pathway. Basically, both of them will require C3 activation. Other one is also the C-reactive proteins, where the phosphorylcholine microbes, dead cells are involved. This is more into the other microbiology and immunology. We may not bother about this. In the transplantation field, it is these two which are important for us. Lectin pathway also is less involved, but it can be seen. MSP1 and 2 can also be seen if we don't see much of this C4D activity. Now coming to C4D negative ABMR, we saw that C4D positive ABMR, it causes severe injury. We are well aware. Now what about the C4D negative ABMR? The first evidence was, of course, noted by Fuchs et al. At Paris and Edmonton group, where they found out C4D negative acute ABMR. And here they saw that there was high level of expression of endothelial specific gene expression, which is the NDATs, in the renal transplant patients with DSA without C4D deposits. That is how the whole thing with the expression of NDATs, the C4D negative acute ABMR concept came up. The peculiarity here was that there was high intragraft endothelial gene expression. There were alloantibodies in the serum, and histopathology revealed ABMR, and they had poor outcome. And this usually occurs within the first year of transplantation. If we look to the basic difference between C4D positive and C4D negative, it is only the C4D. Otherwise, the pathway is fairly similar. Serologically, both will have DSA, both will have histopathological evidence of the acute tissue injury, as well as the, even if it is a chronic ABMR, both will have the same, except for this C4D negative staining and increased expressions of the NDATs, mRNA, and PCAM and SLA on the cellular surface. This is the most crucial in C4D ABMR. Now, why is it that C4D is not deposited on the PTC membranes in all ABMRs? Either it could be low C4D deposition, that is in a low amount, which is not picked up by any of these techniques, or there could be a technical error because of the fixatives or low exposure, etc. Or there could be endothelial cell activation despite poor complement fixing ability of the certain. So there are certain DSAs which don't have the complement fixing ability, but the endothelial cell activation is quite significant. Other is waxing and waning deposition, or prophylactic strategies to decrease ABMR have been employed, then you may not see it. And acute rejection if it is mediated by the Fc receptor on NK cells. Even this, if it is there, then you will not see the C4D deposition on the PTCs. Now, this was what was talked previously. Now, the recent BAF meeting in 2022, what is it that they are talking about the ABMR and C4D? So, what was suspected ABMR or suspicious ABMR? Now what we were talking it as suspicious AMR because the C4D was noted or not noted. Now they have said that this could be probable antibody mediated rejection and start treating it. So now the BAMF group has come to that conclusion that even if C4D is negative, it could be probable ABMR and start treating it. So this is what the latest BAMF 22 report says about the reappraisal of the MVA, that is microvascular inflammation. And they're also talking of the biopsy-based transcript diagnosis. But basically both are important is what they say. Now let me share our experience at IKD. This was of course 5 years before they are talking about the probable ABMR. We had studied for 4 years biopsies with immunological injury in our setup, and we divided them into 3 groups. One was pure ABMR, one was ABMR with T-cell rejections or the cell-mediated injuries, that was group 2, and third was only the cellular rejections. These ABMR were again divided into C4D positive and C4D negative in both the groups. So group 1A and 1B is C4D positive ABMR and C4D negative ABMR. Group 2 was again divided into C4D positive 2A and negative 2B, and the third one was on pure T-cell rejection. Total number of biopsies were 1220, 534 were adequate. We further, when we looked into them, of course, males are more, all of us know the male recipients are more than females in the young age group of 30. So this part is all more or less equal. The number of biopsies, ABMR was 202, combined was 280, and only T cell was 52. So the maximum number was combined T plus B cell or cellular and humoral rejections, and minimum was pure cellular rejections. Now the injuries which were found were in the first year of transplantation was more. In the C4D negative was 28 or 8.8%, whereas here it is 4.6%. C4D combined cellular and humoral was 11.9%, and after 1 year it was 8.3. So total of C4D negative ABMR was 20% if we take both of them, and here it was 12.9% after 1 year. As against that, C4D positive was of course much more than these two. T cell is of course less, we will not touch upon it. C4D positive was 32.8% in the first year and 27% after 1 year, and combined was 34.7 and 52.5. That means what we found was that C4D positive ABMR with or without TCR was more than the C4D negative. Total C4D positivity was 67.5% even before 1 year and 79.6% after 1 year. Coming to the post-transplant, this was a period, it is around 2 to 3 months. And this is again the same, this is little earlier. Mean serum creatinine is more or less similar. It is higher, of course, with the C4D positivity as compared to later on. And graft loss, we can see that with C4D positive, it was 15.2% compared to C4D negative. Similarly, after 1 year, it was, if the C4D was positive, graft loss is definitely higher, as was we also found out. If we correlate with the HLA match, again, better the match, better is the survival. C4D negative ABMR has better outcome than C4D positive ABMR, but this is only in the terms of the HLA matches. Better HLA match, better outcome. What we found over the years, the creatinine was lower in the C4D positive, but the loss was higher. Perhaps this was noted because of the aggressive management. So even at 10 years, we could save them because of the aggressive approach in the management. Serum creatinine, as you can see, as I mentioned earlier, the serum creatinine at 5 years was lower in spite of the positivity. This is because of aggressive approach. What was the treatment? Or perhaps it was the T cell rejection was not there with the ABMR. It was just the antibody mediated. And as we know, for the ABMR, it is rituximab, MP, plasmapheresis, and BOT. Whereas in T cell, we also added the R-ATG. Otherwise, it is more or less the same management. What is the experience of others? Now, Orandi et al., one thing is clear that C4D positive and C4D negative ABMR show similar frequencies of concurrent cell-mediated rejection, and that both may occur early or late post-transplant. So that is clear. It can occur anytime in the life of a graft. But if it is C4D is positive, of course, it is more serious, so it has to be taken more seriously. Orandi and et al., they have studied 207 grafts, 1 year follow-up, where they saw that serum creatinine with C4D was 1, whereas in C4D negative it was 1.3. Even we have seen the same thing at 4 years, of course. Our 4-year follow-up showed C4D negativity, serum creatinine was 1.86 compared to C4D positive. And the graft survival was little better. C4D negative had better graft survival, though the creatinine was little higher. Now, by own research work, I would like to share with all of you with the stem cells. Why I'm showing this is that the role of DSA can be better appreciated by this temporal studies which we have done. It appears to be a little difficult to understand, but I'll try to explain to you how we did it. This is a patient. This was, of course, our work combined with Teresa K. This was a transplant patient. who underwent the renal transplantation with the details are mentioned here. This is patient's HLA and this is the donor's HLA status. So this was HLA mismatch 1, 2, 3, 4, A, B, C, DR, B1, B and DQ. So these were the differences. On the this is the y-axis, which shows the mean fluorescent antibodies, both donor specific and non-specific. This is x-axis shows that the days of the transplant. So we were monitoring before the transplant. As you can see, before the transplant, the various HLAs were up to 8,000. With the stem cell protocol, we brought them down to almost zero, transplanted. And fortunately, all across, there was no antibody noted at all. So the number of cells infused were peripheral blood stem cells, so were of this much quantity, the cultured bone marrow, that is hematopoietic and CD34 and adipocytoid mesenchymal stem cells. This all was infused into the liver and that is a portal circulation. This is the amount, and also the thymic. His serum creatinine was for several years. Now, of course, since I've come to NMC, I've lost the follow-up, but he was maintaining normal graft function with no immunosuppression at all. So no DSAs, no rejection, normal graft. Even the biopsy was proven. This is a second case. There were non-donor specific antibodies, but perhaps it's even after several years, the graft has been protected, living a normal life with 1.1 milligram of serum creatinine, no C4D, no immunosuppression. So even if there are some antibodies, there is no rejection and it can be protected. This is what I would like to share with all of you. And the 20 years experience of renal allograft survival using the stem cell theory at IKDRC, these are the patients on minimal immunosuppression, living a normal life with minimal, as you can see, this is the time period and the cumulative survival of this. This is published now in the textbook of kidney transplantation. Those interested can study and get more insights into the details of this work. So to conclude, friends, C4D negative ABMR usually presents little earlier than C4D positive ABMR. It is less common compared with the C4D positive ABMR. But it is the presence of donor-specific antibodies which is more important, and the labs should establish the immunology lab to measure the DSAs. It is more important than just the C4D in the diagnosis and management of acute antibody-mediated or the chronic antibody-mediated rejections. Graft survival appears to be better in the patients with C4D negative group as compared with the C4D positive group in spite of the higher serum creatinine levels. And of course, this requires an equally aggressive therapeutic intervention as the C4D positive antibody-mediated rejections. So to conclude, I would always, of course, my job will be incomplete if I don't acknowledge all the inputs, whatever training I have received from our guru, Professor H.L. Trivedi, the founder and our mentor of the university and the IKDRC ITS, and my colleague now who is now in the guts, Lavlesh Nigam, who has helped me prepare this slides. Thank you very much.
Thank you very much, madam, for this wonderful, lucid presentation. And thank you for sharing your personal experiences, case studies with us. There are few questions should we take them, ma'am?
Yes, please, go ahead.
Yeah. Can C4D be falsely positive? Someone asked, ma'am.
Yeah, that's what I stated, that if it is not properly stained, but usually it will not come out falsely positive. It can be false negative, not positive.
So, and always we should use the control, right, ma'am? As you said.
Yes. And for controls, you can take up a lupus slide, which is easily available, or you can even take up which is difficult to get an ABO incompatible graft. If you have it, of course, that's very good.
Yes. Ma'am, granular or linear C4D staining is important, ma'am, to
Yes,
call it
it is
positive.
very important. It should be nicely circumferential across the peritubular capillary membranes. Sometimes what happens, it is intense, too much of staining, it takes up granular, but it has to
Appear.
be along the membranes and circumferential.
Okay, sure. And ma'am, can we have both DSA negative and C4D negative ABMR supported by LM findings alone?
At least I have not come across that.
Yes, ma'am. One question is for HLA antibody, we categorize them as donor specific or donor non-specific. So
Right.
does it apply for non-HLA antibodies like MICA antibody also?
See, MIC are known to cause chronic after years together. When you see that, you are not able to see anything, just like your previous question that there's a rejection, still it's negative.
Mhm.
That could be chronic injury, and if we get a chance to measure the endothelial antibodies or the MICs, and I believe Terasaki's group, perhaps Mickey, and they are doing some work. I've not been able to take up the recent work, but if something of that kind is there, it could happen, but not otherwise.
Sure.
Yeah.
Yes, ma'am. How do you immunosuppress a patient undergone bone marrow transplant from same donor? Do we do chimerism testing before transplanting the kidney in a recipient who has received bone marrow from the same donor?
It's good if you can do it. It's better than you know what is the status.
Yes,
I
sir.
used to do that when I was there in fish by fish technique. In fact, what I was doing was when we put the stem cells, I would do fish and do the counting. I've published some papers about that. That was one way. Now there are more and more things coming up. It could be done.
Okay,
So
ma'am.
then we will have a better idea. Then what you can do, somebody can take up this research project before, during, afterwards, waxing and waning for how long it remains, the percentage, and you can measure the chimerism in the marrow, in the periphery, or in the tissue. It can be done at various levels. I even tried to do it along the in the kidney biopsies also. This was in the very many years back. I used to do that.
Great. Ma'am, how do we differentiate acute tubular injury due to ABMR from any other causes like CNI related? Someone asked.
CNI related will have isometric vacuolization. Look to the dose. There are other simple tricks. For example, there is severe CNI toxicity. Patient's weight, if it is well monitored, you will know the patient will be losing the weight, whereas if it is rejection, there will be weight gain, tenderness of the graft, all this will be counting together. Simply, the C2 levels may not always be helping out. We have noted that C2 levels, the trough levels may not be always be indicative. But certain clues you can take it up. And the graft injury, of course, for the CNI toxicity, you'll see isometric vacuolization in the tubules. That can help.
Which is more sensitive for detecting C4D by immunohistochemistry or by immunofluorescence, according to you, madam?
I was enjoying IF better.
IF, immunofluorescence.
Yes.
The chimerism you just mentioned, was
Yes.
it like B cell chimerism or T cell chimerism?
It can be both. You have to study both.
Okay, madam.
Yeah.
I think, yeah,
In
that's.
fact, I used to do even the T cells, monocytes, etc. That also can be worked up.
Okay. So I think, yeah, the questions are done. Thank you
so
very much, ma'am. Despite being so busy, but being teacher.
But I'm happy to come back to academics after a long time. Thank you and Manish and everybody. It's been ages now that I've seen them, but thank you so much.
Yes, ma'am. Thank
Yeah.
you, ma'am. Thank you.
Okay.
Pleasure.
Thank
Thank
you.
you all the attendants. Thank you.